Okay, so we might just, in the interest of time, just press on, and I'd just like to introduce our next speaker, Monica Diaz. She is the nurse and midwife consultant for the South Australian Perinatal Practice Guidelines, which I love and use all the time. She's a PhD candidate at the University of South Australia and a Churchill Fellow. Her research focus includes childbirth-related perineal trauma, culturally safe care for women with female genital mutilation or cutting, and equitable health outcomes for women from culturally and linguistically diverse backgrounds. Thank you, Monica.
Thank you for inviting me here today to present a little bit of information about how we can begin the conversation around female genital mutilation cutting with women who present to our services. I would like to acknowledge the complexity and sensitive nature of this topic. The information that is being presented here today comes from women that I interviewed as part of my PhD study. So this is information that they've felt that this is what us as clinicians need to know. All effort has been made to ensure that the content of this presentation is culturally appropriate and respects the experiences of those women that trusted me with their stories. So I know most of you know what female genital mutilation is. I just wanted to give you a little bit of background before getting into it all. So to put it into context, female genital mutilation, or FGMC, is defined as all procedures that involve the partial or complete removal of the external female genitalia or any other injury to the female genital organs for non-medical reasons. It is classified into 4 types. Type 1 and 2 is probably the most common, and that makes up about 90% of the cases in clinical practice. That is often the ones that we miss because it's so difficult to know who has it. And sometimes, we're so focused on the labour and birth or other things that we just completely miss it. Type 3, which is probably considered the most extreme form, is also known as infibulation, makes up about 10% of the cases, and that's the ones that we always, when I talk to clinicians, they're like, oh yeah, I've seen FGM, and they're referring to type 3. It is estimated that 200 million women have FGMC worldwide, and another 3 million women and children are at risk of having the procedure done every year. It is found in 92 countries around the world, including here in Australia. So why does it matter? Why is it important for us as clinicians to know? Well, women with FGMC can have significant immediate and lifelong complications as a result of the procedure. And many of them are also at increase of adverse maternal and neonatal outcomes during pregnancy and childbirth. So as clinicians, we really need to know who these women are and how to best support them in a culturally safe manner. Now my slider is not working, but I just wanted to have like a show of hand and I'm hoping that there's many of you who has actually cared for a woman or a family who has had FGMC. Yes, so quite a lot of people, absolutely. And how confident did you feel discussing FGMC with women? Not very confident. I see a few shakes of hand. Yeah, your head. Yeah, you felt very confident. That's good. So it varies, but predominantly the literature even states this, that as healthcare professionals, because we don't see it that often and it's not included as part of our traditional sort of education, we don't feel confident to discuss it or to bring up the conversation. So how do we do this? One of the things that we need to begin by understanding is like the barriers that women might feel they have when talking to us about FGMC. And one of them is that it is considered a taboo subject. For many women, this is a very personal thing, something that they don't even discuss with their own mothers. So it's very personal. No one talks about it. It depends on where they come from. Some communities are a lot more open and they do have those discussions, but most of them aren't. So first of all, understand that that can be a difficult thing to talk about. Many women also feel embarrassed to talk about it. They feel scared that maybe there'll be some repercussions, especially because FGMC is illegal here in Australia. So women don't want to tell you that they have it, just in case something else is going to happen to them. And we also got to understand that a lot of these women are from refugee backgrounds, so their visas are very protected, and they're very concerned about those sorts of issues. All women, especially the ones that I interviewed, spoke English was their second language, and for many it was almost like their third or fourth language. So we have to understand that even though they may actually speak English or understand English, they may need a bit of longer time to discuss FGMC with a clinician. And many of the women that we also spoke to didn't know that they had FGMC until they actually accessed health services. And that's because often it is done during infancy when they're quite young. And again, it's not something people talk about, so they don't know. I had one of the women that I interviewed said it wasn't until she was at school and they were talking about it at school for some reason, the other kids. And so she went home and asked her dad, and her dad was like, yeah, we just cut a bit. And that's basically the quote of my, at the beginning of my presentation. She just said they just cut a bit. Like it was just so matter of fact, like nothing significant, I guess, for her. Also, we need to understand our own biases. A lot of the women said that healthcare professionals, as well as intended as we are, our body language tells us straight away that when we're feeling uncomfortable about a situation. So they felt that was kind of very puts them off having the conversation. Also using language such as, oh, you poor thing, that sort of thing is sort of victimizes the woman, and no one wants to feel that way. So understanding our own biases around it. Another thing that's really important is understanding the environment. I did a Churchill Fellowship back in 2018, and I visited quite a few clinics in Europe. And in one of them, one of the midwives said that she had a woman come in and she took her into the treatment room to discuss FGMC. And the woman panicked, had a full meltdown, didn't want to go into the room. And so they had to go somewhere else. And then on discussion, what happened is that back in her country, FGMC is medicalised, so it's done in a hospital or in a clinic. And where she had the procedure done was a treatment room. So seeing the sign that said the treatment room just made her completely upset about it. So understanding that women come with a lot of psychological trauma as well, and that may be triggered at any one time. So we need to be gentle and open to having those discussions with them. And also another important thing to understand is, why do we need to know a woman's FGMC status? Because women are more likely to talk to us and share that information if they know the purpose of having that information. So to begin with, I think a really good idea is to sort of set the scene for her. So if you want to talk about FGMC, ideally bring it up in the antenatal, that first antenatal appointment. I know it is one of those questions that we usually tick as well. And so you could ask, for this assessment, I would like you to ask you a few questions that will help us understand your health and cultural needs so we can better care for you. Is that okay? So that already gives back the woman some power about this conversation. She may want a bit more information, but generally women are very open to having those discussions when they feel comfortable. So what can you ask? I know this is one of the questions that I get often. How do you talk to women about it? Because, it's a difficult topic. So you can always start, have you heard of female genital mutilation cutting or female circumcision? You can also, if she says, no, I haven't, then you can also ask where you come from. Does your community practice any tradition or rituals for girls or women? Because then that may make them go, oh yeah, I remember, like, this is what we used to do. And then you can have a conversation around that a little bit more and investigate, and then also find out what that tradition is called, because for women they might go circumcision, I don't understand that, but in her community maybe the term sunnah is something that they use, or cutting, or pharaohic circumcision. So there's lots of different terms, so understanding what she understands is really important. And then if she says no, or she refuses, like she does, not refuses, but she doesn't know, it doesn't necessarily mean that she doesn't have FGMC. So it's really important to know that we need to be asking other questions. And in this instance, what I would recommend is finding out about their health needs. So taking a health history, finding out whether they have recurrent UTIs or painful intercourse or troubles with menstruation, any of those sorts of things that may trigger us to go, ooh, like what is happening there? What is the cause of that? That's another way that you can approach it for a woman who doesn't really want to discuss it or doesn't know that she has FGMC. Another thing that you can do is use visual aids. However, you really need to be sensitive with this. We don't have any sort of, the two pictures in the middle are from New South Wales and Western Australia. There are flip charts that have been created by clinicians, but they haven't actually worked in collaboration with women. So we, in my project, are actually currently working with women and developing a visual aid that is culturally safe and appropriate to use. But to start off, until that happens, what we can start using is other things. So having like a uncut genital picture, and that's quite safe to use. And having the conversation around educating women, and just explaining what their structures do, what is the purpose of them. And more often than not, women will go, oh, actually, I don't look like that, or, that looks different to me. And that's when you can start thinking, oh, okay, maybe this woman has FGMC. It's also important to note that it's not necessary to do a physical examination unless the woman specifically requests it, okay? Women feel very embarrassed and, they want to protect their privacy, which is fair enough. So we don't need to be looking unless she actually wants to know exactly what type of FGMC she has. And then other considerations that we need to take into account, if possible or where possible, consider female healthcare providers. I know sometimes that can be quite difficult at times, especially if you need a doctor and you're in the middle of the night and all the team is male. So things that you can be asking is, what do you do in your country to be culturally safe around a male doctor or male practitioner? And women often will tell you what they need to feel safe and to be able to communicate. And from the women that I interviewed, they all talked about having their husbands there. That was very important. So facilitating that is one way that we can ensure that women are protected. One of the women I interviewed said, only my husband, we can't even have our sister or our mother there, it has to be our husband. So it's really important that we understand that as well. Interpreters is another important thing, and something that I actually learned during these interviews is that sometimes having an interpreter for a specific language doesn't necessarily mean that they will understand that language, because there's different dialects. So it's really important that we know, are they able to understand that interpreter? And the other thing as well is that if it's a very small community, do they know them in the community? And which means that woman is not going to want to talk about anything personal in case that goes back to the community. So understanding that is also important. One way that we can, I guess, minimize that is using continuity of care models where we have community health workers that have been trained and are part of the hospital, and that can be there and support the women from a culturally safe point of view. Because often, a lot of the time, we might understand cultural traditions and, you know, translate things into their language, but sometimes you don't know those little things that make up a culture, you know, like things that only a person who has lived in that environment can go, oh, actually, you know, I know what's happening here, you know, and understands the situation a little bit better. Community engagement, or ensuring that we work together with communities to develop and design guidelines and education is extremely important, something that we really need to implement and support. And that's part of something that we're doing currently at UniSA through my PhD project, where we have interviewed women and we've invited women to talk to us about what education we need to provide to healthcare professionals to ensure that we provide a culturally safe care. And so that leads me to my next slide. So we, at the moment, are now, we have developed and piloted this program. It's a South Australian Female Genital Mutilation Cutting Education, or SAFE program. And we are looking for midwives and nurses who are interested in being part of the evaluation. It's a statewide thing. It's specific to South Australia, because in South Australia we don't have any specific supportive services for women unless they're going to refugee health services in the city. So if you are interested, there's a QR code at the end of my presentation that you can look at, or you can email me directly and just pass on the word for anyone who might be interested. It is a two-part course. One is done online and one done is face-to-face or in a virtual environment. And then you get also 4 CPD points. And, oh, sorry. Trying to go back to my slide. And that's it. Oh, my last slide is not there. But if you need any more information, please let me know. Thank you.